We're going to talk about HOD, or hospital outpatient, versus at the surgery center. I have no industry disclosure, but I am a medical director and shareholder at surgery center in my practice. So you have a simple case, lumbar discectomy, lumbar decompression, ACDF. Your options are either doing it at the hospital but going home the same day versus doing it at an outpatient surgery center that you may or may not own shares of. This brings us to the site of service differential, even though you're doing the same surgery at one of two different places. So reimbursement over the years is very disparate between the hospital and the ASC. And on the physician side, the CMS uses hospital outpatient prospective payment system for determining payment, whereas at ASCs, CMS will use the Medicare physician fee schedule. So that being said, even though there is a difference, the surgeon reimbursement on your side is about the same. However, on the facility side, ASCs are typically reimbursed about 53% of what the hospital would get for doing the same procedure at the hospital as an outpatient. So the question is, why did this happen? What was the difference? So this happened because of a differential in the annually adjusted payments based upon differential in rates of inflation measures that they use for different between HOD and ASC. So for years, the CMS has used what's called the hospital market basket in order to determine inflation rates, and that's based upon the cost of healthcare goods and personnel expenses specifically related to healthcare. However, before 2019, ASCs were being measured based upon the consumer price index, and as you can imagine, the healthcare inflation far outpaces inflation in the general inflation in the United States. So in 2019, they switched them both to the healthcare market basket. But at this point, HOD prices are now far higher and are going to continue to rise at a faster rate because of this difference. So for patients, there can also be a difference too that we need to keep in mind. For Medicare, one of the things that we need to keep in mind about is that patients typically have an out-of-pocket expense of 20%, whether it's done at a surgery center or the hospital. Okay. However, at the hospital, that 20% is applied to their inpatient deductible cap, which right now is about almost $1,700. Okay. At the surgery center, though, there's no caps on co-payments. So if it's late in the year, people have hit their deductible. If they do it at a surgery center, a patient may balk because, well, I already hit my deductible at the hospital, but not necessarily at the surgery center. Okay. So therefore, even though surgery centers are going to have lower costs, lower charges, the inpatient or the patient's financial responsibility may be higher. Okay. So there's lots of benefits for ASCs. Typically, our costs are lower, which makes sense because we're making 50 cents on the dollar compared to the hospitals. We have to have lower expenses. Safety is equivalent or better in terms of quality of care, and surgical site infections have been shown to be over 50% less than at a hospital. Okay. There's convenience and accessibility in terms of, these are surgery centers that are most often run by doctors who are going to control operations and the value of care. So you're going to have better, more specialized pre- and post-operative care. Okay. From a patient side, patient satisfaction is often higher at the surgery center. Time spent, patients typically go home 26% quicker from a surgery center than from a hospital as an outpatient. And the main thing is predictable scheduling for surgeons. So if you have 5 or 6 cases scheduled at a surgery center, you're not going to get bumped for the emergency appendectomy or the trauma case. So the chance of having to reschedule or delay cases is very low. So the benefits are that, surgery centers are going to be smaller, highly specialized, and highly efficient. The surgeries are screened in terms of select surgeries and the patients themselves. And the most important thing is that the cases that you're choosing to do at a surgery center should be highly reproducible with expected outcomes. I can't stress that enough. So because you're on an island, if there's a cardiopulmonary complication off campus and the patient's going to have to be stabilized and then transferred for potential interventional cardiology care if that's necessary. Okay. So when you're considering where to do it, okay, we've got to talk about case selection, safety issues, and then a little bit about insurance and coding. So at most surgery centers, anesthesia is going to screen for medical clearance, specifically related to BMI, sleep apnea, make sure they have a normal airway, check their medical comorbidities, and most importantly, no personal or family history even of a history of malignant hyperthermia, which could be devastating in that kind of setting. On the physician side, length and complexity of surgery is paramount. Okay, so if you're doing a complex surgery that's your 6th-time revision on somebody that's had 4 CSF leaks and you don't know if you're going to have to put in a lumbar drain or dural patch or whatever, not a great case to do at a surgery center. You go on screen, if you're going to take out a 30-year-old anterior cervical plate and you don't know if you're going to have the right screwdriver, again, that's not a great place to do, not a thing to do at a surgery center. Got to look for blood loss. And importantly, that we don't really think about a lot is the patient's social issues, okay? You want to make sure that the patient has family support and has reasonable expectations about their postoperative time at home. Okay, I'd always tell patients, if you and I have different expectations, one of us is going to be disappointed, and usually it's not me. So these are the cases that we do at our surgery center, what you would expect: lumbar discectomies, decompressions, synovial cysts, cervical fusions, cervical decompressions, highly selected fusions, peripheral nerves, and spinal cord stimulators. So in terms of safety, a few years ago, there was an article that came out in the lay press looking at a highly select group of patients that ended up getting picked up by the lay media, looked at 5 years worth of cases, but it only took 12,000 state and Medicare records, and said that there was 260 deaths, which would be a 2% death rate overall and 0.1% in the spine population. Now, that's not consistent with my practice or most of our practices, I think. And it was extensively covered in the lay press. But if you look, during that period of time, they ended up saying that, surgery centers are not safe. People in some of our organizations were saying that we shouldn't be doing spine surgery at surgery centers. But during that period of time, that 5-year period, there was 200 million cases that were done at surgery centers in all specialties across the country. So there's a lot of literature. I'm not going to go into all of it now, but if you look at this one meta-analysis, here's 19 studies that looked at 17,000 patients, and the transfer rate was less than 2%. There was no mortality, and all morbidity was similar to inpatient. So, it's been proven that there's ample evidence that spine surgery can be done safely and effectively in an ambulatory surgery center setting. So in terms of coding and reimbursement issues, the main limitation for most surgery centers is in-network versus out-of-network for the insurance. And to be honest, it can take years to negotiate contracts with payers. As you can imagine, they don't always negotiate in good faith, and they have little incentive to put you in network, even though you cost less. We had one payer say that they'd be happy to put us in network for 60% of Medicare. It took us 4 years to get a reasonable contract with that payer. But that's the main limitation, because even though you can make it cost neutral, most patients are going to want to go with the cheapest option, which can be more expensive if you're out of network. The other thing that would limit that has limited is the inpatient-only list. Okay, so over the years, spine surgery has several spine surgeries have been removed, including lumbar interbody fusion. I remember when cervical fusions if it was Medicare, couldn't do them at an outpatient surgery center. Synovial cyst was just removed a few years ago. And if you go to orthopedics, they've had total joint replacements removed for several years now. So in terms of Medicare, the main thing right now that limits it is 1 or 2 level ACDFs for straight Medicare patient or patients who have Medicare payers is okay. But if you do a 3-level anterior cervical fusion, the code 22846, which is your 3-level cervical plate, is currently on the inpatient-only list. The thing to remember about this is that if it's a commercial payer, inpatient-only list doesn't really apply, so they can still be done if it's a select patient that's appropriate. And the other thing is that the inpatient-only list has got to be discontinued next year. So in terms of considerations, you have to take into consideration your financial issues for your patients. Obviously, there's financial considerations in terms of the physician and what can be done best for the practice. Patients got to be screened for medical and surgical risk factors. And you got to keep in mind these coding issues, both for getting pre-certification as well as getting reimbursement. So thank you very much for your time.